Today let us see about the acromioclavicular joint instability. Okay, and before going to the acromioclavicular joint instability, let us see about the basic anatomy of the acromioclavicular joint, its biomechanics, and what are the movements possible at the acromioclavicular joint. So as I told, the acromio AC joint instability, and AC joint instability is otherwise known as the shoulder separation. What do you mean by shoulder separation? Shoulder separation is nothing but the acromion process of the scapula is separated from the clavicle. And let us see about the acromioclavicular joint. So what is the basic anatomy of the acromioclavicular joint? So the acromioclavicular joint is the articulation between the acromion process of the scapula and the lateral end of the clavicle. Okay, and this is a plain synovial joint. The acromioclavicular joint is a plain synovial joint, and it has got an articular disc. It has got a synovial joint capsule and two ligaments associated with this joint. What are those ligaments and what is the function of these ligaments? The main function of these ligaments is to hold the acromion process with the clavicle. Okay, and when you think of the shoulder separation, what actually happened here is there is a tear in these ligaments which will cause separation of the acromion process from the clavicle. What are those ligaments? The first ligament is the acromioclavicular ligament. The first ligament is the acromioclavicular ligament, and it has got two portions. One is called the superior acromioclavicular ligament and the second one is called the inferior acromioclavicular ligament. And the second ligament is the coracoacromial ligament. Again, this coracoacromial ligament also got the two portions. One is the medial portion called the conoid ligament and the lateral portion called the trapezoid ligament. This is the basic anatomy of the acromioclavicular joint. Now let us see what are the movements possible at the acromioclavicular joint. So as I told, the acromioclavicular joint is a plain synovial joint. So when we think about the plain synovial joint, what will come to your mind? The only movements that is possible at the plain synovial joint is the gliding movements. So most of us had studied in our college days as a plain synovial joint. Acromioclavicular joint is a plain synovial joint where the movements possible are the gliding movements. But acromioclavicular joint is one of a confusing joint where there is actually 6 movements are possible. Are you guys surprised? 6 movements are possible. Of these 6 movements, 3 movements are the rotatory movements. 3 movements are the rotatory movements and 3 movements are the translatory movements. Now let us see what are those movements. It's a little bit confusing. I try to explain in a way that you guys understand. So what are the movements? The first movement is the medial and lateral rotation of the scapula. The second movement is the anterior and posterior tipping of the scapula, and the third movement is the upward and downward rotation of the scapula. And the main important thing is that when you think of the acromioclavicular joint, when you think of the internal and external rotation of the scapula, this is the movement of the scapula in relation to the clavicle. This is very, very, very important. When you think about the acromioclavicular joint, this is the movement of the scapula in relation to the clavicle. Don't get confused with the movement of the scapula with the humerus movement, or the movement of the scapula in relation to the sternum, or the movement of the scapula in relation to the thorax. That movement is different. When you think about the internal and external rotation at the glenohumeral joint, this is the movement of the scapula in relation to the humerus. Okay. Whereas when you think the upward or downward motion of the scapula in relation to the thorax, this is considered as a scapulothoracic movement. Okay. So when I think about the AC joint movement, always keep in your mind that it is the movement of the scapula in relation to the clavicle. Now let us see the first movement. Which is the first movement? The internal and external rotation of the scapula. So what is an internal and external rotation of the scapula? The internal and external rotation. So the scapula moves internally and the scapula moves externally. Here you have to focus on how the glenoid fossa moves, because it is very hard to visualize the movement that is taking place at the acromioclavicular joint, because these movements are very minimal. So in order to analyze the movement, you have to focus on the movement of the glenoid fossa. So what is the movement that is occurring at the glenoid fossa during internal and external rotation of the scapula? During the internal rotation of the scapula, the glenoid fossa is moving anteriorly and medially. Okay, during internal rotation of the scapula, the glenoid fossa is rotating anteriorly and medially. This anterior movement of the glenoid fossa is considered. So when you think about the anterior rotation of the glenoid fossa, actually the movement is occurring at the acromioclavicular joint. Since the movement at the acromioclavicular joint is minimal and hard to visualize, you have to focus on the glenoid fossa. Okay, so the anterior rotation of the glenoid fossa is considered as a rotatory movement, and when the glenoid fossa moves anteriorly, there is also a medial movement is also taking place. That medial movement is considered as the translatory movement. Got it? So that's the movement, internal and external. Then what is the external rotation? When the scapula is going for an external rotation, focus on the glenoid fossa. The glenoid fossa is rotating posteriorly. The glenoid fossa is rotating posteriorly and laterally. Got it? So during internal rotation of the scapula, the glenoid fossa, you have to focus on the movement occurring at the glenoid fossa in order to have a better analysis, in order to have a better visualization of the movement that is occurring at the acromioclavicular joint. So internal rotation, the glenoid fossa is moving anteriorly, which is considered as a rotatory movement, and the glenoid fossa is moving medially, which is considered as a translatory movement. So when the scapula is going for external rotation, the opposite movement is happening. There is a posterior rotation is happening, as well as a lateral translatory movement is occurring. Okay. So that is about the internal and external rotation. And in which plane and which axis the acromioclavicular internal and external rotation take place. So this is little bit different from the normal or the conventional cardinal planes of motions. So when you think about the conventional cardinal planes of motions, when you go for internal and external rotation at the glenohumeral joint, which is the axis and which is the plane? The plane is the plane which divides the body into an upper half and lower half. So the plane where the internal and extension occurs at the glenohumeral joint is the transverse plane, and the axis which is perpendicular to the transverse plane is the vertical or the longitudinal axis. But when you think of the acromioclavicular joint motion, this is entirely different from the conventional cardinal planes. Here the plane of motion is the scapular plane of motion. What do you mean by the scapular plane of motion? So I'll give an example. If you want to do shoulder abduction at the gym, you are doing abduction, strengthening of the shoulder joint. So this is the abduction of the shoulder joint in the conventional cardinal plane. So which is this plane? This plane is the plane which divides the body, the front and the back halves. So abduction and adduction occurs in a frontal or the coronal plane, and axis is the anterior posterior axis. The axis is the anterior posterior axis or the sagittal axis. So when you are doing an abduction and adduction at the glenohumeral joint, the plane of motion, the plane is the coronal plane or the frontal or the coronal plane, and axis is an anterior posterior axis or the sagittal axis. But the same movement, if you want to do it in the scapular plane, you rotate the shoulder about 30 to 45 degrees and do shoulder abduction, and this movement is occurring at the scapular plane. So that's about the scapular plane. So when you think about the scapular plane of motion, always think that there is a 30 to 45 degrees of rotation occurring at the plane of the scapula, whichever movement is taking place. So when you think of the internal and external rotation of the scapula, the plane is the scapular plane. So when you think of the scapular plane, it is always rotated, tilted 30 to 45 degrees. So usually the plane where the rotatory movements, internal and external rotation is occurring is the transverse plane, but in the acromioclavicular joint, the scapular, it occurs in the scapular plane. So when it occurs at the scapular plane, this plane will rotate 30 to 45 degrees. So if this is the transverse plane, the scapular plane is tilting, the scapular plane is tilted 30 to 45 degrees. So when the plane is tilted 30 to 45 degrees, the axis won't be a perpendicular axis. The axis will always an oblique axis. You got it? Since the scapular plane is tilted 30 to 45 degrees, the axis which correspond to the scapular plane will be an oblique axis. So the internal and external rotation of the scapula at the acromioclavicular joint occurs at the scapular plane around an oblique vertical axis, not a perpendicular axis. It is an oblique vertical axis. You got it? And next comes to the second movement at the acromioclavicular joint is the anterior and posterior tipping or tilting of the scapula. The anterior and posterior tipping or the tilting of the scapula. So here you have to focus on the movement of the acromion process of the scapula. So during anterior tipping, the acromion process is moving anteriorly as well as moving forward. So the anterior rotation of the acromion process is considered as a rotatory movement, and the forward movement of the acromion process is considered as the translatory movement. Okay, and during the posterior tilting or the posterior tipping, the acromion process is rotating posteriorly. At the same time, the acromion process is translating backward. So each movement at the acromioclavicular joint is a combination of a rotatory movement as well as a translatory movement. Okay, so anterior tilting or the anterior tipping, the focus should be on the acromion process of the scapula. So the anterior tipping or the anterior tilting is the anterior rotation of the acromion process of the scapula. At the same time, the acromion process is translating forward. In a posterior tipping or the posterior tilting, the acromion process is rotating posteriorly, as well as the acromion process is translating backwards. And again, one more confusing thing in this particular movement is that in some book, the anterior and posterior tilting of the scapula is explained in regard to the movement that is taking place at the inferior angle of the scapula. In some book I had seen that anterior tilting of the scapula they are explaining as a posterior movement of the inferior angle of the scapula. The same movement. So when you think, when this scapula, when the acromion process is rotating anteriorly, what is happening to the inferior angle of the scapula? The inferior angle of the scapula is moving backwards or moving posteriorly. So anterior tilting can be explained in a different way also. So whenever there is an anterior tilting or anterior tipping at the acromioclavicular joint, the acromion process is rotating anteriorly as well as it is translating forward. Simultaneously, the inferior angle of the scapula is moving backwards. And in posterior rotation, the acromion process is rotating posteriorly and it is translating backwards. At the same time, the inferior angle of the scapula is moving anteriorly. Okay, so don't get confused with these two versions of anterior and posterior tilting or tipping. And where is the axis and the plane? So the plane of motion is the scapular plane of motion. So when you think of the anterior and posterior motion, this is almost similar to the movement that is happening at the glenohumeral joint. Which movement? The flexion as well as extension. So the axis for this movement, the forward and backward rotation, the forward and backward tilting of the scapula is an inclined coronal axis, frontal or the coronal axis. So the plane is the scapular plane. Again, the scapular plane is tilted 30 to 45 degrees. And when you think of the plane, what will be the plane? So in the glenohumeral joint, this movement is similar to the movement that, which is the movement, this is the flexion and extension, flexion and extension. So which plane and which axis flexion and extension occurs at the glenohumeral joint? Flexion and extension occurs at the sagittal plane, and the axis is the coronal axis or the frontal axis. So in the acromioclavicular anterior and posterior, the movement occurs at the scapular plane of motion, where the scapula is tilted 30 degrees, 30 to 45 degrees. So how the scapula will be tilted? The scapula will be tilted. So imagine which is the plane corresponding to the same motion at the glenohumeral joint is the sagittal plane. So how the sagittal plane divides the body? Sagittal plane divides the body into a right and the left half. So the scapula will be tilting 35 to 45 degrees. 35 to 45 degrees. So the scapular tilting is like this in the scapular plane. So the axis will be an oblique axis. The oblique axis which passes is the coronal or the frontal axis. The oblique, coronal or frontal axis. And coming to the third movement that is possible at the acromioclavicular joint is the upward and the downward rotation of the scapula. And this downward and upward and downward rotation, what happened? Again, your focus during the upward and downward rotation of the scapula is at the glenoid fossa. So here the glenoid fossa is moving superiorly during upward rotation, and the glenoid fossa is rotating inferiorly during downward rotation. So when the glenoid fossa is moving, when the glenoid fossa is rotating superiorly, what is happening? The acromion process, what is the movement? There is an upward movement is occurring at the acromioclavicular joint. At the same time, when there is an upward rotation occurring at the acromioclavicular joint, there is a simultaneous superior translatory movement is also occurring at the acromioclavicular joint during upward rotation. And what will happen during the downward rotation? The focus should be at the glenoid fossa. The glenoid fossa is rotating downwards. So what is the movement that is occurring at the acromioclavicular joint? There is a downward or an inferior rotation occurs at the acromioclavicular joint. At the same time, there is a downward translatory movement is also, or an inferior translatory movement is also taking place at the acromioclavicular joint. Okay, so and which axis and which plane? The plane that correspond to this movement, so the upward and downward movement of the scapula. So imagine this simultaneous movement or the similar movement that is happening at the glenohumeral joint is the abduction and the adduction at the glenohumeral joint. The abduction and the adduction. So abduction and adduction at the glenohumeral joint is taking place in which plane and which axis? The plane is the plane which divides the body into a front and the back half is the coronal plane or the frontal plane. And which is the axis? The axis will be an anterior posterior axis or the sagittal axis. The anterior posterior axis or the sagittal axis. So here at the acromioclavicular joint, the upward and downward rotation of the scapula, the downward and upward rotation of the scapula is taking place in the scapular plane, and which will be the axis. It is an oblique anterior posterior axis. So the plane will be the scapular plane. So in this in the glenohumeral joint, the plane will be a frontal or the coronal plane. So when you compare this plane at the scapular compared to the scapular plane, so the scapular plane will be like this. The scapular plane will be tilted like this, and the axis is an anterior posterior axis. So it is an inclined anterior posterior axis which passes through the acromioclavicular joint. Okay, so that's about the movements that is taking place at the acromioclavicular joint. Okay, now let us see about the pathology that is occurring at the acromioclavicular joint. So AC joint instability or the AC joint separation. So it's a little bit confusing topic. That's why I want to make you understand what are the movements possible. Okay, excuse me. Okay, now let us see about the shoulder separation. Okay, so what are the causes for shoulder separation? Of course, the main cause is the traumatic cause. It can happen due to accidents, then hit on the acromion process, fall on the outstretched hand, and fall on the elbow. So, and these occurs at accidents or during contact sports. So these are the causes. So it can occur mainly due to trauma occurring with the accidents or with any contact sports. Then the fall on the outstretched hand, then fall on the elbow are some of the causes. Next, see what are the clinical features. What are the clinical features for AC joint separation? The first clinical feature is that pain, pain during movements, pain. So which all movements produces pain at the acromioclavicular joint? So pain mainly occurs during cross body adduction or the horizontal adduction or the transverse adduction. The patient complains of pain, and again pain occurs when you keep the hand behind the back. Pain occurs during the hand behind the back, or the pain also occurs when the patient try to do abduction or flexion through elevation. That is the extreme end range of motion. Pain mainly occurs at the end range of motion during abduction or flexion through elevation. Okay, and again there is a swelling present and tenderness along the joint line. And when you think about the pain during acromioclavicular joint, the patient complains of pain mainly on the top of the shoulder. The pain at the top of the shoulder. Then coming to the deformity. So what you can see in case of acromioclavicular joint separation. So when the acromioclavicular joint is separated, so in a normal anatomy, in a normal joint, the clavicle as well as the acromion process are held together by the ligaments, the acromioclavicular ligament as well as the coracoclavicular ligament. So when there is any injury occurs, what happens is that the clavicle as well as the acromion process and the clavicle get separated. The clavicle moves away from the acromion process. So what will happen? When the clavicle moves away from the acromion, the clavicle will move up and laterally. And what will happen to the scapula, including the acromion process? The acromion process as well as the scapula moves downwards. Why the scapula is moving downwards? Due to the pull of the gravity as well as the weight of the upper extremity. Scapula is pulled downwards, or scapula moves inferiorly, and the clavicle is moving or protruded laterally. So when you move your hand on the separated shoulder, you can see a bump present. You can feel a bump on the lateral aspect of the shoulder. Or in some books they are saying that you can see a step deformity. And this, don't confuse with the step deformity. So when you think about the step deformity, it is the step deformity at the shoulder joint. There is again a step deformity. That step deformity you can see in case of spondylolisthesis when there is an anterior displacement of the vertebra or the other. So that step deformity you can see in case of spondylolisthesis. And this step deformity, when you are talking about the step deformity, you have to specify that the step deformity in case of acromioclavicular joint, where since there is a separation of the acromioclavicular joint, the clavicle is protruded laterally and the scapula moves inferiorly, and when we moves our hand on the lateral aspect of the shoulder joint, you can feel a step or a bump. And again, as I told, when the clavicle is protruded laterally, what can happen? This can cause injury to the muscles, especially to the deltoid muscles as well as the trapezius muscle. There can be tear in the trapezius muscle or the deltoid muscle. Okay, the involvement of the trapezius muscles as well as the deltoid muscle we can see in detail when we look into the X-ray findings in case of acromioclavicular joint separation. That's the X-ray findings, that is Rockwood classification. Okay. So that's about the clinical features, that is about the signs and symptoms. Now let us see what is the clinical test for AC joint separation. So for one test is the acromioclavicular resisted extension test. So here the therapist should stand at the back of the affected side of the patient. So the therapist asks the patient to flex his shoulder 90 degrees, flex the shoulder 90 degrees, elbow 90 degree flex, internally rotate the shoulder. So flex the shoulder 90 degrees, flex the shoulder 90 degrees, elbow flexed 90 degrees, and internally rotate the shoulder. Then therapist will resist the horizontal abduction. Then resist the horizontal abduction, patient complains of severe pain. Okay, so that's called the acromioclavicular resisted extension test. And the other test is that ask the patient, this is a simple test, ask the patient to do cross body adduction or horizontal adduction or the transverse adduction. The patient complains of pain. Okay, then other test is the acromioclavicular compression test. The patient in a sitting position, therapist should stand on the side or the affected side. Then therapist, what he has to do is that he has to give a simultaneous compression on the anterior as well as posterior aspect of the acromioclavicular joint. Give a compression on the anterior as well as the posterior aspect of the acromioclavicular joint. The patient complains of pain. So that is called the acromioclavicular compression test. Then again you can ask the patient to do the extreme range of end range of shoulder abduction through elevation or flexion through elevation. Patient of course will complains of pain. Again you can ask the patient to keep the hand behind the back. The patient will complains of pain in case of acromioclavicular joint separation. And now let us see the radiographic findings. It's a radiographic findings in the acromioclavicular joint separation is very, very important. This is called as the Rockwood classification. Rockwood classification. So the Rockwood classification. So this Rockwood classification you can analyze by looking into the X-rays. And when you go for an acromioclavicular X-ray, the Rockwood classification, to figure out the Rockwood classification in X-ray, always recommend to go for the stress X-ray. What do you mean by the stress X-ray? What is called the stress X-ray? Stress. So actually we are stressing the acromioclavicular joint. So here we are giving an inferior stress at the acromioclavicular joint. So here ask the patient to hold dumbbells. So the maximum weight the dumbbell the patient is holding is between 5 to 15 pounds. 5 to 15 pounds is the maximum weight the patient can hold in case of inferior stress test. So ask the patient to hold the dumbbells. The weight of the dumbbells range between 5 to 15 pounds and the X-ray is taken because acromioclavicular joint is a very small joint and the proper separation, especially the acromioclavicular joint separation as well as the coracoclavicular spacing can be seen only if you are giving an inferior stress. Okay, so ask the patient to hold the dumbbells. That is so by holding the dumbbells we are providing an inferior stressing at the acromioclavicular joint. So this and the X-ray is taken is known as the Rockwood classification, and actually there are 6 classification comes under Rockwood classification of the X-ray. The first classification can be called as a type 1 or the sprain of the acromioclavicular joint. Okay, only the sprain. Type 1 is called as the sprain of the acromioclavicular joint. Here, what are the things you can see? So, in the type 1 or the sprain at the acromioclavicular joint, there is only a sprain at the acromioclavicular ligament. Okay, only there is a sprain at the acromioclavicular ligament. The coracoclavicular ligament is intact. Coracoclavicular ligament is intact. The joint capsule is intact. The joint capsule is intact. Again, the deltoid as well as the trapezius, there is no detachment of deltoid as well as the trapezius muscle. There is no detachment of the deltoid as well as the trapezius muscle. So why you have to specify only the deltoid and the trapezius muscle? And this deltoid and trapezius muscle has got very common similarities. The origin of the deltoid muscle, is same as that of the insertion of the trapezius muscle. When I say the similar means the deltoid muscle, the anterior fibers of the deltoid muscle originate from the anterior as well as the lateral 1/3 of the clavicle. The middle fibers arises from the acromion process of the scapula, and the posterior fibers arises from the spine of the scapula. And when you think about the trapezius muscle insertion, the upper fibers of the trapezius muscle is inserted into the posterior as well as the lateral 1/3 of the clavicle, and the middle fibers of the trapezius inserted into the acromion process, and the lower fibers of the trapezius is inserted into the spine of the scapula. So that's the reason why the trapezius muscle and the deltoid muscle are more prone to injury when there is an acromioclavicular joint separation. So the type 1 sprain, there is only a sprain of the acromioclavicular ligament. The coracoclavicular ligament is intact, the joint capsule is intact, and there is no injury occurring at the deltoid muscle or the trapezius muscle. And type 2 injury, Rockwood classification, is called as the subluxation of the acromioclavicular joint. So there is a partial dislocation, that is called the subluxation. So in the type 2 subluxation, there is a tear occurs at the acromioclavicular ligament. There is a tear or a rupture occurs at the acromioclavicular ligament. There is a sprain occurs at the coracoclavicular ligament. There is a injury occurring to the joint capsule. There is the joint capsule are torn, and there is a minimal detachment of the deltoid as well as the trapezius muscle, and there is a minimal separation at the acromioclavicular joint. So what is the normal acromioclavicular joint separation? Acromioclavicular spacing, normal spacing of the acromioclavicular joint spacing, the acromioclavicular joint, the normal spacing is less than 8 millimeters. Less than 8 millimeters. The normal is less than 8 millimeters. And when you think about the coracoclavicular spacing, the coracoclavicular spacing is between 11 to 13 millimeter. Okay, is 11 to 13 millimeter. So in case of a second degree Rockwood or type 2 Rockwood classification, there is an increased spacing occurs at the acromioclavicular joint. Increased spacing greater than 7 millimeter to 8 millimeter. Okay. Now the third degree is dislocation. In the third degree, there is a dislocation, and in the third degree, what happened? There is a rupture of the acromioclavicular ligament, there is a rupture of the coracoclavicular ligament, the joint capsule is torn, there is maximal detachment of the deltoid as well as the trapezius muscle. And again, what happened is that the clavicle is moving superiorly. The clavicle is moving upwards, and there is an increased spacing occurs at the acromioclavicular joint, and the corococlavicular spacing is also increased greater than 13 millimeters. And coming to the grade 4 or the type 4 classification, here again there is a rupture of the corococlavicular ligament, rupture of the acromioclavicular ligament, rupture of the joint capsule. There is a maximal detachment of the deltoid as well as the trapezius muscle, and there is a increased acromioclavicular as well as the corococlavicular spacing. And in the fourth degree of the Rockwood classification, the clavicle can be seen posterior, and it can be seen near to the trapezius muscle, and this kind of injury is considered as a rare type of injury. Okay. And type 5 has got the same clinical features like this rupture of the acromioclavicular ligament, rupture of the corococlavicular ligament, the joint capsule is torn, there is a maximal detachment of the deltoid as well as trapezius muscle, there will be a maximum spacing occurs at the acromioclavicular as well as corococlavicular spacing, and there is a elevated position of the clavicle. And coming to the last stage, the stage 6 or the type 6 of the Rockwood classification is the same that of the type 5. The only difference is that the clavicle can be seen inferiorly and it can be seen behind the coracobrachialis or the biceps brachii muscle, which is considered as a very rare type of injury. Okay. So that's about the acromioclavicular joint biomechanics as well as the pathology of the acromioclavicular joint. So I tried to simplify this, but still the video is almost 45 minutes. So this is a very important topic, and in the college time, probably you just studied about the acromioclavicular joint as a plain synovial joint where the gliding movements are only possible. But when you analyze this movement, so these are the movements that is possible at the acromioclavicular. So acromioclavicular joint has got total 6 movements, 3 rotatory movements as well as the 3 translatory movements. Hope you guys understand this video, and we'll see you in another video. Till then, bye bye. Thank you.